Thank you all, and I'm sorry I was not able to be there in person today for this workshop because I was needed here in the ministry for some urgent work. But anyway, I've been just popping in and out of the workshop today since morning, and I've been hearing to some interesting sessions going on there. It was wonderful. So last session was really wonderful, where you had to see a hands-on approach on how to do the qualitative analysis. And this is very much required because this is one part of research which is really missing. This is very much important in our context, and I'll come to that why it is important later on. So as we go ahead, if you want to look at popularity of yoga today, amount of research is going on yoga is tremendous, enormous. And if you look at if you use the keywords meditation on PubMed, you get 9,569 articles, and if you use keyword yoga, you get 7,542 articles. Reason why you get different articles as for meditation and as far as yoga is concerned is because meditation became more popular in Western countries in the 1960s, even before yoga as a part of the intervention came into being. Okay, so a lot of meditative traditions like mindfulness technique, Maharshi Maheshwari Yogi standard, which has transcendental meditation, and so on and so forth. Many of them started popping up in US, and a lot of interest was there on these meditative traditions, and that's why you see large number of articles on meditation compared to yoga. If you look at the articles from 1973 onwards, just talk about RCTs. So when you talk about qualitative research, we don't mean RCTs, because RCTs is mainly to do with your quantitative research. 900 articles on RCTs on yoga, 1,022 on RCTs on meditation. Okay? And if you want to look at the exponential increase in yoga articles, after 2014, that is when International Day of Yoga was coined by UN. You can see here, in 2009-34, we have about 4,309 articles. In the sense, for past 75 years, up to 2014, we had 2,934 articles in yoga, keyword yoga. As the last 7.5 years, and 10th of that period, we have double the amount of articles on yoga. Okay, so exponential 1,000 times increase in articles on yoga. Same thing with respect to meditation as well. You see the number of articles on meditation 75 years is 4,048. That is the last 7 years or so, 7.5 years or so, it's 4,952 itself. So there's a tremendous popularity and use of yoga and meditation in various aspects of care as well, where they're using it as a therapy. Recent article which I want to quote, which is published in Journal of American Board of Family Medicine. And there they have done a very nice survey on looking at electronic health records. Okay, in the last 10 years, 50,976 patients and 2,398 clinicians, 41 clinical service departments were affiliated with yoga notes. In the sense, they use the term yoga, either they prescribed yoga or they wanted to ascertain whether the patient was doing yoga in their clinical notes. This is very important. This showed that a 10.4-fold increase during the 10-year study period between 2006 to 2016 alone. So 2.6% of these patients had at least one mention of yoga in their notes. So this is again a qualitative study where you are doing a data mining, looking at EHR, and to find out various aspects of yoga here. Other aspects of the study also was there. Looked at barriers and all. We won't come to that. This is an example of how they really want to look at qualitative research on based on documentation here, clinical documentation here. Okay, and this has been published. And if you try to find out this kind of qualitative research on yoga, you hardly would find any articles except for 3 or 4 studies which are there, which have some amount of qualitative input. There are mixed method studies also where both qualitative and quantitative are also used, and I'll come to that later on. So when you talk about today's presentation, I want to talk about, just make you to recapitulate what is qualitative research, qualitative data, which all of you know about it since morning, qualitative analysis, software, and qualitative reporting. So what I'm trying to do here is into these aspects into yoga research. So I'm going to give you examples, questions, and so what is qualitative research? It's nothing but development of concepts which help us to understand social phenomena in a natural setting, even due emphasis to the meanings, experiences, and views of the participants. So you're not doing experimental setting here. You have a clinic, patients are coming to a clinic, they're asking you questions, you are interviewing them, to ascertain certain aspects and certain concerns of the patient. You are using them in your qualitative data analysis. Okay, simple as that, real-time setting. That's where here, this real-time settings, when you start publishing something, they can be a lot of bias as well, because you don't have any randomization, etc. And you have purposes sampling here. And in the last session, I heard that about error. So error is nothing but it is investigator error, basically, investigator bias. If you are not going to be having that bias inside you, then there won't be any error in your study. So that is what you need to really work to limit your bias when you do the study. When I talk about yoga here, I'm going to give you an example about yoga in cancer patients. Okay, you know that many of the cancer patients are sick, they receive surgery, chemotherapy, they receive radiation. Many of them have advanced disease, they go into metastatic disease, go into palliative care settings, and so on and so forth. So one of the primary concerns of any patient which comes to me is, they say there are two aspects of it. One is the positive on the left side, you can see, on the right side you can see, and the negative on the left side you can see. You need to be flexible. So for doing yoga, you have to be flexible. People may say, oh, I break my bones, it's not for me. Okay, these are negative aspects of it. It causes more discomfort, can interfere with my treatment. I have fatigue already. I already have fatigue, I can't do yoga now. I can't commute to class daily. Can I believe what my instructor says? Let me check with my doctor. They don't believe the instructor also, the therapist is saying. It is Hindu religion, yoga is to do with Hinduism. Okay, these are some of the concerns which patients really also have. They even talk to the doctor when they ask these questions to the doctor. Like for example, I did have some patients of mine but objection in chanting Om. Okay, didn't want to chant Omkar. Okay, so I said, don't chant Omkar, chant Akar, chant Ukar, Makar, whatever you want to chant, you chant some monosyllable, doesn't matter. So don't chant Omkar. Okay, so these are some of the concerns which patients have. So how do you document these concerns? Because these are very important, because this helps you to develop a proper yoga module which can be tailored to all the religions. Right? It can also help you understand concerns of various patients. Here you can address concerns of patients who are on cancer. For example, patients with cancer or aromatase inhibitors long time, you can get osteoporosis, and doing more of acute breathing asanas can also cause fractures. So we need to be aware of these scenarios. We need to also educate the patients about these scenarios as well. Okay, some people think doing yoga would improve immunity on the positive side. Yoga would cure cancer. They think by doing Kundalini yoga, I'll be activating my chakras. That can also have magic powers in curing my cancer. So if we talk about more oxygen, pranayama, more breathing, more oxygen means decreasing the tumor cells, killing of tumor cells. So all these things which are there, beliefs which are there, the attributes and the perceptions which are there in the patients can really change the decision of the patient for doing yoga or not doing yoga. Okay. So what's important here is information. Giving the right information to the patient is very, very important. Trying to understand patient expectations is important. Trying to understand patient perception of yoga is important, what yoga is actually. Trying to understand what sort of myths they have related to yoga or related to cancer is also very, very important for us. Because these all cannot come with experimental studies. These all can only come by using qualitative research. This can be really ascertained by doing proper interviews in the clinic or inside the yoga department or yoga care clinic, whatever it is. Okay. So if you look at the continuum here, we have quantitative data, qualitative data. So initially, scientists in earlier were saying there's no such thing as qualitative data. Everything is 0 or 1. It means it's a form of a measurement. You have something, you don't have something. Okay. They started deciphering all the data into numerical part of it, measurement part of it, objective part of it, this quantifiable part of it. Later on, they also started understanding that everything cannot be quantifiable. There are certain things which also have to have a qualitative grounding. Okay, Campbell is one who really proponent this theory of qualitative research initially, and a lot of work has been done since then, from 1960s onwards in this area. So dimensions of qualitative methods are fourfold. One is understand the context. For example, understanding context means what? How economic, political, social, cultural, environmental, organizational factors influence health. Okay. What is it around the patient? Okay, the environment, the community around the patient, how does it influence his perception of health? How does it influence his way of understanding health? Okay, so all these things are very, very important. These are patients in a palliative care. So I'll give an example. What do you mean by palliative? Patients don't know what palliative is. The moment we say we want to give palliative chemotherapy, that means to think that it's end of life care. So it's nothing for them. So they have very severe, they are terminally ill, they are going to go to hospice care, and they think it in another way. Don't understand what palliative really means. Okay, so all these perceptions are very important, and these are all guided by the environment, the stimuli around them. Okay, understanding people, how people make sense of their experience of health and disease, like patient perspectives on physical activity, patient perspective on lifestyle, medication, health behaviors, etc. For example, a diabetes patient. Sometimes some people get a diagnosis of a simple disease like diabetes. Okay, they think it's a very big disease for them. Okay, they do a lot of activity, they become physically active, they take up on themselves, etc. There are other people who don't want to bother about diabetes, carry on with their health behaviors, they smoke, they drink, they glutton and they eat more amount of food, they do binge eating, everything they do. Okay, they don't bother about it. So patient perspective changes as we understand one to other. Different extremes. One of them will be too overtly conscious about it and trying to follow things religiously what the doctor says. Some people don't care anything about it at all. Okay, so we still see patients in the radiation department in oncology setting, where instead of having head and neck cancer, instead of being counseled not to take tobacco, they come with the tobacco put in their mouth doing radiation therapy. Okay, and we have to make them spit it out. So these are all part of health behaviors. What understanding the people have. Okay? So we can see two extremes of people, and this kind of survey, when it's done, you do this kind of qualitative data, you have to look at all both the extremes. We have to have a very good sampling technique wherein we can look at the low socioeconomic strata, middle strata, and the high socioeconomic strata as well. But across all the status, across all the educational status, which can be confounders, across age, across gender differences, can bring about a proper answer to your particular research question. Okay, these are where things can be confounding. These are the things, but these are called the confounders or errors in the qualitative research. So unless you try to minimize these confounders in your study design itself, when you do the recruitment itself, then the errors can be really taken care of. Suppose you did a study only on youngsters, so this is more applicable to youngsters. You did only on males, it's more applicable to males. Okay, so there comes the bias there, and there comes the error for qualitative research. How you choose your patients. Okay? Understanding interaction is another concept. How various actors involved in different public health activities interact with each other, like patient-doctor communication. What does the patient ask the doctor? What does the doctor ask the patient? Simple example I'll give you. We did a survey on these patients of stage 1 and 2 cancer patients, all solid tumors, breast cancer, head and neck cancer, ovarian cancer, lung cancer, and so on and so forth. And we just asked them how many of them practice complementary and alternative medicine. Okay. We had a big questionnaire survey which they filled it up, and we found out, our surprise, that 25% of the patients in the primary cancer-related treatment, complementary alternative medicine, 70% of these 25% don't tell doctor that they're taking homeopathy, they're taking Ayurveda, they're taking some other kind of treatment. Okay, it only came out when the interview was done with the patient. So this is understanding the patient-physician communication is also very important, because some things patients don't want to tell the doctor doesn't want to ask something to the patient. Okay, unless that those and that's the way only qualitative research will help us to find out what are these things which need to be asked in a patient-patient communication. So afterwards, when we found this was the criteria, then we made a change in our case sheet as well. We made mandatory that patients we also write down if they are taking any other form of treatment. Okay, so this gave insight into that particular aspect of the care. So understanding patients' beliefs and expectations is also very, very important, because what do they expect from these kinds of treatment, like yoga treatment? Does it cure my cancer? Okay, and does it yoga means more oxygenation by doing pranayama, etc. Does it help in increasing immunity against cancer? They have so many types of questions. Okay, they also ask whether stress has caused my cancer. I don't have any habits. Still I have got cancer. Stress is the cause for my cancer. They have no answers to those. So understanding the patient's beliefs, expectations. And I also had a particular case of patient who was blaming her mother for cancer. Okay, Okay, she was blaming her mother for cancer because her mother was very strict with her and was disciplining her, lifestyle, etc. This lady, this young girl was just had completed graduation, had a very early breast cancer, and she was too much stressed out. And she said her mother is the cause for all her cancers. So many things are there which happens in a patient which really doesn't get into a record. It is just a conversation which happens between the doctor and the patient, but these things are also very, very important because these things can also really change the way the cancer progression can also occur. For example, the patient conflict was there between the mother and the daughter, and that conflict could have really prevented the patient from taking the help of her mother as a caregiver. This can have serious consequences to the her treatment itself. That restriction could go on and on. So that restriction required a lot of counseling and communication. So qualitative research is about finding what are the areas, what are the things which can be really addressed to improve quality of life of these patients. It does not have to be necessarily be some sort of a number or some sort of a hypothesis all the time. Okay? So qualitative and quantitative basic differences you already know. Okay? So you have to describe a situation in qualitative, gain insight into particular practice, more predetermined response for the categories, in-depth explanatory data from a small sample, draws out patterns from these concepts and insights. So all it does is draws out different kinds of patterns, okay, different kinds of behaviors, and ranks these particular patterns and behaviors. So basically what it's doing is ranking them. Okay, this is the more dominant among all these patterns. Okay, and then based on those you can use it to do more other amount of quantitative research later on. So quantitative and explanation and individual responses are more there, more of theoretical compared to statistical you see in quantitative. So again, more if you want to look at research question, it is more broad, it is contextual, it is flexible. Example, needs and expectations. Whereas in case of quantitative, it's a patient satisfaction. So you give a satisfaction questionnaire, as the patient rate from 1 to 10, how much satisfied is it the care given by the hospital, care given by the nurses, care given by the staff, okay, regarding the hospital environment, so on and so forth, on about 10 to 12 questions or whatever it is. And gives you a number basically. Out of 80, you got 40, 50, etc. Thus, these expectations are different things. So the patient would probably say, I need to have a bar on the bathroom because I have disability. It's very difficult for me to go to the bathroom. This is something different thing which cannot be really quantified in any sort of research. It's more qualitative in nature. Okay, so expected outcome is not predefined. The emergent research question, example themes, you can get thematic choose out of it. I'll come to the themes later on. And it is more of observational in kind rather than deductory or experimental in kind. And it is prone to biases. That's what I was talking about. Errors in qualitative research is nothing but biases. So if you want to confirm the bias, you need to have a whole broad population, broad age, broad gender, okay, and then do this thing and try to find out what confounding factors can really be there in that particular research question you're asking. And it will minimize those biases, minimize those confounders. So these are nothing but errors in your qualitative data. Then you have qualitative versus quantitative. Again, you have sampling. It is open-ended, structured, protocols, flexible. Most often it is purposive sampling. Those who give more time, who give consent to take their data, ready to give an audio interview, okay, where you can record the interview as well. So the people you want to take, right? So as compared to quantitative, it's always random sampling. So it depends on interactive interviews, depends on structured data collection. And results which gives a lot of meaning and experience and views. This is very, very important. Qualitative data is more about giving you meaning and experience and views of the patient. And these qualitative data is much important because it's known to improve the quality of care in a particular healthcare setting. So if you want to really improve quality of care, you won't go with RCT trials or anything of the sort. You go with qualitative data. Okay? And how to do this qualitative analysis? I'll give an example of patients' needs and expectations on being admitted to a palliative care unit. So you do an interview first, ask them how old are you, how do you come from, you are being admitted to a palliative care unit for the first time, how have you been since you arrived, what is the association with the palliative care unit, and remember the moment you were asked about being admitted to a palliative care unit. So you keep on asking some sort of interviews, slowly go into the second part of it where you ask more detailed kind of questions. Go to the details of it later on. Similarly, if you go to patient comes to yoga department in cancer center, old are you? Where are you from? You know about yoga. So please tell us about what you know. We ascertain from patients what do they know about yoga. So what is their perception about yoga? What other treatments you are currently taking? You have symptoms in starting cancer treatment. Are your needs and distress being addressed by the team here? Do you think yoga will help you deal with your cancer? Okay. Then second interview, as you go down, again one more, perceive yoga. How do you perceive yoga would help you? You have concerns regarding yoga for a condition. You feel that you don't have energy, stamina, flexibility to do yoga. You think you can't do yoga. So these are questions which a doctor probably can ask. The patient doesn't ask these questions. So we usually don't give leading questions in the interview. It is only given as a prompts are given to the patient to elicit more information from the patients. Okay, this is how an interview should start progressing. Get more and more information regarding patients. So this is how we want to get qualitative data on yoga. This is how we do. The context here would be probably cancer patients. So let's come to the context and themes later on. So here, for example, this is my theme. Okay, I have a topic: patient needs and expectations from yoga department in a cancer center. This is my topic. So what are the themes I had? I want to know about information about yoga. I want to know about patient needs and expectations from yoga. I want to know about the patient's qualities required of a yoga therapist from a patient's perspective. I want to know about what is it being treated in a yoga therapy unit inside a cancer office. Okay. So what is categories, purpose of yoga department, type of yoga practices, I break it down further department. So clarity on yoga, clarity on the type of practices, clarity on the purpose of yoga, what this yoga can really do. That is what is the example of course which I do for the particular interview. And patient needs and expectations from yoga department, I talk about improvement, quality of life, talk about reduction in distress, they talk about immunity, resilience, better coping with stress, and stress and situation at home, also social concerns, finances, even visitation concerns for yoga class, dependency on yoga caregivers. Like if I ask the patient to come for 3 times a day for a week, the hospital, he is dependent on her caregiver to bring her to the hospital and take her back. Patient is sick. Okay, there is a time constraint, there is money, financial constraint, there is dependency on somebody else. So these are all some of the concerns which come out with the interviewers. And patient expectations. They need to have, they want to know that the yoga person is knowledgeable, is honest, and is very patient to listen to the patient. So listening ability is very important. Okay, should ascertain feedback from the patient after doing yoga class. You just do the yoga class. Did the yoga class help the patient or not? Or no? You need to ask the patient how much did it help. So can you do anything more to address his concerns? These are important. And if there is any negative perception regarding yoga, regarding safety of yoga practices, safety of yoga practice associated with religion. Okay, so all these things, fears have to be allayed, especially if you find some Muslim person or some Christian or some other person from other religion into practice yoga. I did have a pastor coming and doing yoga with me. We never had this concern. Okay? So some people do have concerns. Some of the nuns who had breast cancer did have some concerns regarding yoga. So they were very upfront about it and they were talking to me and they said, don't do these practices. We like to do more of asanas, more of breathing. No chanting, no mantras, nothing. Okay, so we were happy with that. Okay. So we need to be looking at some of the perceptions what they have. Some of them can be guided by their own religion also, their religious beliefs. We need to respect that as well. Okay. So positive perceptions, again, this is again negative perception is again opinion contrary to oncologists. For example, oncologists would say the patient do this yoga and will help you to reduce the stress and help you this thing. Because the yoga therapist says that the yoga, don't take the medication, your symptoms will go away with yoga only, you don't need to take this medication. That's contrary to what your doctor is saying. Right? So yoga practices will improve my health, yoga practices will improve my anti-cancer treatment, that's all fine. You need to have proper communication between the doctor and the yoga therapist. And that positiveness should be itself. So if there is a conflict between what doctor is saying and what the yoga therapist or physician is saying, is going to be a problem. So that can be a negative perception as well. Okay. So response from interviews like palliative care unit, I won't go into details regarding this. So palliative care, for example, if I see more details the same way the teams, the example I want to give is patient expectations and needs in a palliative care unit. Okay, information about palliative care. Okay, you need to improve quality of life, is a place for dying, lack of information, source of information. They think palliative care is nothing but it's a hospice care for the patients. This is very important for them to allay this particular fear. Palliative care doesn't mean end of life care alone, doesn't mean hospice care alone. It is very important for us to educate the patient. Situation at home, social concerns, finances, vision for future, quality of symptom management, quality of life and symptom improvement, okay, and communication, respectfulness, honesty, taking time. All these things are some of the important aspects. Negative perceptions in cancer patients would be lack of information, too intense treatment. They feel they don't want to go to the treatment because, for example, taking highly emetogenic chemotherapy, too much of nausea, vomiting, anticipatory symptoms. They don't want to come and take next chemotherapy at all. Okay, so these are some things which you need to really understand when you want to do a qualitative study. So you break up this, you make this particular kind of a chart before you start doing any sort of study, and try to make these are some of the important things could be there. And do you start doing the interview, then you can see what outputs these things can come. Okay, it's very easy to do that kind of things. So approach analysis was both deductive approach, okay. So like what I just put it now, or inductive approach. Okay. So for example, in deductive approach, the patient with advanced cancers have differing needs and expectations than others. Okay, but you don't know what it is. So you're just going and complete it of all of the patients, both with early cancers and advanced cancers, and then trying to find out what is the difference there. Okay. Inductive approach is needs and expectations of cancer patients in palliative care setting. So you know what is it you're trying to work on, the palliative care setting of cancer patients. You're only working on the particular thematic approach. Okay, it's called inductive approach. So a lot of tools are there. You can use summaries, you can use self memos, record, you can use a researcher diary, you can have audio recordings of the patients. So all these notes can help in developing the paragraphs which you saw for doing qualitative research analysis. Okay. So terms using qualitative data, you have theory, themes, characteristics, coding sorts, indexing. I think you already have gone through all of this. I won't go into details of this. So these are various principles of qualitative data analysis. One is understanding the people differ in their experience, understanding of reality. Example, fatigue versus pain. When you go for a cancer patient, when a poor patient is there in immunotherapy, he really doesn't know how to discern what is fatigue and what is pain. Sometimes pain is also perceived as fatigue for them. Okay, a lot of studies have been done in that show that people perceive pain as also fatigue. Okay? The social phenomenon cannot be understood outside its own context. It can be context bound. For example, family members want to prevent the patient from knowing that they have cancer. They have a conspiracy of silence to collaborate with the doctor, with the onco-physician, not to tell the patient about the diagnosis. This can create unnecessary isolation and anxiety. Okay? And those kind of things are happening. It's very difficult to do qualitative study. Okay? Because the patient will not be able to tell what she has, and you should not be knowing about her diagnosis, and she will not be knowing that she had cancer or anything. Okay? So that again becomes a problem there. So qualitative research can be used to describe phenomena or generate theory rooted on data. Understanding human behavior emerges slowly and non-linearly. So whatever comes out of a qualitative research is not expected rarely. So you can expect some things which can come out of it when you already have an inductive approach. Some things may also come out, some new things may also come out when you start going deeper into respiratory phenomena of this qualitative research. Okay? Exceptional cases may yield insights into a problem or a new idea for further inquiry. For example, we were looking at patients doing rounds, integrative oncology rounds in the hospital. We were treating patients with fatigue, we were treating patients with anxiety, depression, sleep disorders, and myofascial pain syndromes, etc. We have never treated patients with dyspnea. So we thought patient is having lung cancer, has pure effusion, and dyspnea is going to be there, and I don't think yoga can really help. Okay, that was our perception, our doctor's perception that way. So we just thought, let's try doing something for patients. Let's see what can be done, because patient is always on oxygen. The moment you take out the oxygen, the breathless again, and oxygen saturation dips the patient. So we start training the patient in a prone position, sitting prone position, Shashankasana, it's called a rabbit pose. Started treating them to do breathing exercise, deep breathing in that particular posture. What we saw was, doing Shashankasana, when they have dyspnea like this, when they have pure effusion, they were able to breathe much easier, okay, and their oxygen saturation was still maintained. Okay, this is one thing which we could tell patients that you could do this at home. Whenever you have distress, when you feel your oxygen levels are low, this could be, you don't require oxygen supplementation, this could be done in borderline cases. This we learned only after experience. Okay? When we saw, and this also it was done by one of the patients themselves. Just crouching and then trying to breathe. Then we understood we could do Shashankasana for the patient. Okay? and it was working wonders for the patient. So this is something which will really come out of discussion with the patient. Okay. So process of qualitative data, as you already seen, organizing the data, identifying the framework, sort the data into framework, use framework for descriptive analysis. Then you have what is called second order analysis also. I won't go into details. So you have the software for doing this. So what you do is you transfer the data. The software is also available called HyperTranscribe. And transfer the data. If there is a different language, you can use System, the translator for audio recordings. Again, there are problems with this particular audio recordings. It's always not accurate. Okay. Once you do the transcription, you have to clean the data. A lot of spelling mistakes, errors, all those things have to be cleaned up. Label the data, structuring and summarizing the data is very, very important. Okay? Understand attributes, very important. As you go through all the paragraphs, you have to make your own notes. What attributes have been answered? Is there a new attribute coming up in your explanation in that particular interview, and go deeper into that. So, identify framework is always, it can be two types. It can be explanatory, guided by the research person or team you have in hand. Explanatory, just going through everything and then finding out and making your own things. Okay, guided by the data. So once you do the framework structuring, you label, define the data, you make a coding plan, etc. You code the data, modify the framework, enter the data using computer packages, which you saw right now. So many computer packages are available. I will show the details of it. And you have a range of responses in categories, identify recurrent themes. In the exploratory research, if the themes are more recurring, you just stop it here only. And if you want to look at different aspects of qualitative analysis, one is called content analysis. Behavioral data is there. Yoga's impact on lifestyle. Narrative analysis, meaning how yoga helped the person. Again, one narrative on how it helped somebody. Discourse analysis, spoken written interaction, concerns regarding yoga. Framework analysis, development of themes, perceptions regarding yoga. Component theory, development of hypotheses from data in a given population. Okay. So does Shashakra help patients with dyspnea? Does pranayama help in phonation and speech in head and neck cancer patients undergoing radiotherapy? Okay. So some important aspects are there which can be really understood by using different aspects of qualitative analysis. Okay. So I'm going to give you an example of clinician documentation, thematic content, and framework analysis. Clinician documentation, example, what are the key elements of yoga as a therapy in cancer? Do a thematic analysis. Patient says like this. Female patient, age 32, married, breast cancer. Patient had mastectomy with ICL clearance 3 months back. On chemotherapy, has CANV, induced nausea, vomiting, has sleep problems, has right arm pain. And undergone 8 sessions of yoga therapy. Is now able to sleep in reduced by 50%, and nausea still persists. He has to continue our sessions and do the practice at home. Okay. This is what is written by a case record. So here, it tells you a lot of things about. Patient is already doing yoga here. Patient has already got despite from yoga here. Some aspects of symptoms still persist, which are not available to a yoga intervention. Only she will require more number of classes. So it tells you how much duration of yoga intervention is useful to impact these kind of symptoms. It tells you various aspects of how you can address these symptoms, how you can address coping here, how you can establish illness understanding in these patients. Okay? You can discuss cancer treatment with these patients, discussing yoga practices and the intended use. Yoga practices are useful for nausea, vomiting, which is useful for managing fatigue, okay, which is useful for facial pain or arm pain. So all those things are very, very important for us to really tell the patient about what would be really best for them. Okay, this is clinician documentation. Yoga therapy introduces systematic content analysis. Same way, yoga clinicians conceptualize and practice for cancer patients. Okay. Focus group analysis is done by focus group discussions. What do you think yoga therapy helps patients build a relationship with the patient? What are the strategies? Okay. It talks about all aspects of it. What are physical symptoms? What are emotional symptoms? What is it? How much this bother you? And how much of them are going to come up in future? Okay. And understanding between the yoga clinician and the doctor again is very, very important, because contradictory approach can become more divisive. Okay. So all these thematic things you can take out and put in a framework analysis and go into that. Then you have a patient-clinician conversations in clinical setting is called framework analysis. And here you build up symptoms, what are symptoms are there, quality of life is there, symptom management, so yoga is there. Because you have a patient to caregiver to self-manage symptoms with yoga, you break up all these into different sections. Okay, and to see how much of these are really answered in the interview process. This is called framework analysis. Your structured approach you have here, the structured approach of the framework to all these aspects. You are able to narrow down your the same. it will be very, very more focused and becomes much easy and reduces the amount of, it will really answer your research question. You just keep talking here, some patients will be talking about their family, they'll be talking about their children, we're talking about somebody else, neighbors, whatever it is. You need to have a framework for discussion because patients don't get much amount of time with the oncologist. They'll get more time with the yoga therapist because they spend 1 hour with him by doing yoga there. So you do not have to spend more time on talking other things. And if you have a focus questionnaire like this is the proper amount of content can be used for generating your qualitative data. So these are qualitative softwares. I want to go deeper. So this you have seen what has already happened and how to use these softwares. Just had a review of it. I won't go into details on this. These are different types of qualitative softwares. Unfortunately, you have to pay to get them, except for some of them like OpenCode and other things which are freely available. Okay? When you have trial versions available, you can use the trial versions of most of these softwares. So to choose software depends upon the type and amount of data. Okay? Depends upon whether you're doing a structured in-depth approach, structured or framework kind of analysis, or an open expert kind of analysis. So based on that, you can choose different kinds of softwares. So I myself don't have much experience with all these softwares. I've used InVivo, I've used the Atlas thing, as well as the OpenCode sometimes, one time. So there will be much seem to talk on this. So again, this is all about qualitative research. You do have qualitative research mixed with quantitative data as well, mixed method research. So here, for example, if I ask a question, how do patient perceptions on yoga therapy relate to differences in test scores on anxiety following a yoga intervention? So I need to have a look at the baseline patient perceptions on yoga. I want to collect the data qualitatively. I want to see how much these qualitative data is having influence on the anxiety scores, quantitative analysis, using a Spielberger's state rate anxiety inventory or a hospital anxiety depression scale. Okay? How does patient expectations and beliefs on yoga reduce symptom scores? Again, this is again a mix and method design. You want to look at patient beliefs, expectations, patients who have more higher expectations, they have reduction symptom scores. We don't know. So that is again a very important aspect to really study also as well. So this is called a mix and method study design, very much useful, especially in case of yoga setting. Why? Because here there's a lot of questions when it comes with yoga intervention when doing a RCT. One, you can't blind a yoga intervention. Okay, sham yoga interventions are really not sham yoga because there's nothing like sham yoga here. Okay, and what they say is the effect of yoga maybe because of the time given to the patients. Okay, and amount of interaction you're doing with the patient. That could be one of the biases and confounding factors with the yoga thing. Third, they also talk about expectations on yoga is so high because of the popularity of yoga. That expectations would also make the patient feel much better. And it can be a placebo effect, we call it as. That could be a placebo effect of yoga intervention. So all these are some of the important aspects which are there. And this mixed method study design will probably help in cutting down those barriers as well. So this is about my talk. I didn't want to go deeper into this because you had a very long day and too much of gyan will just go over your head. So thank you, and I would like to see if you have any questions on this.